All right. So good morning, everyone. Thank you for attending this pre-admission screening and resident review evaluator training. My name is Dr. Jennifer Ochoa. I'm a consulting psychologist with Department of Healthcare. My volume okay? Everything okay in regard to the beginning of this presentation? Everyone can hear me all right?
Yep, sounds good on my end.
Thank you, Thomas. All right, next slide. Thank you. So just some, basic expectations. Unfortunately, it was not automatically muted. So if you haven't muted, please do so now. Any questions, please place in the chat, and we will be able to address any of those questions before the demo at the end of this actual presentation. There we go. Our next slide. So let's start out for the purpose of this training. It is to help us understand and define the level of care of our nursing homes. So we have three levels of cares generally that we will be referring to. The ICF, or the intermediate care facility, the skilled nursing facility, and the STP, or special treatment program facilities. Next slide. So alphabet soup, what is LOC, or level of care? Level of care is the intensity of the medical care being provided by the physician or the healthcare facility. In California, Medicaid certified homes are called skilled nursing facilities rather than nursing facilities or nursing homes. So you will hear me refer to the skilled nursing facility throughout this presentation. When we talk about level of care, this means that the care that is needed must be medically necessary for the resident to obtain the services. And we'll talk further about how you can identify if the services are medically necessary. Next slide. The criteria that helps us define the type of level of care that is needed are these four here. We'll start with medical. Most of the individuals you will be seeing will have a medical issue or diagnosis, and the resident will need assistance with things like catheters, IV drips, ventilators, and other medical necessity devices. Some individuals may have cognitive issues. Now, this is not an individual who only has cognitive issues. We're going to talk about neurocognitive disorder, primary or only diagnoses later, but this is for individuals that have memory issues related to the inability to process information, but not where it is the primary or the only focus of care. The third definition is the mental, which is the inability to control actions or mood, experiencing thought disorder. I know we see a lot of individuals who have had a recent self-harm or suicide attempt, as a result of a mental health disorder. And then lastly, the functional, which is the inability to manage your activities of daily living. That can be all or none of dressing, toileting, eating, being able to care for oneself. Next slide. All Medicaid certified skilled nursing facilities must follow and abide by Title 22 and Title 9. So what does that mean? There are three primary types of level of cares in skilled nursing facilities. Those are the three here, which is the intermediate care, the skilled nursing care, and special treatment programs. And they all are licensed and certified underneath the 22 CCR Division 5, Chapter 3 to 4.5. I did notice that this is in the evaluator handbook or manual. You feel free to review that at your leisure. Go ahead, go to the next slide, please. So, basic understanding of what an ICF level of care facility is. So that means that services provided in the facility are for generally individuals that are identified as developmentally delayed individuals due to and then I'll even clarify that a little bit more. Individuals that have a diagnosed developmental delayed disorder are overseen by the Department of Disabilities. And as such, we have a split in the level of work. I do believe that we will talk a little bit more about that, but this particular type of facility generally meets the needs of those that with developmental disabilities or been diagnosed with a developmental disability. They require protective and supportive care because of mental or physical condition or both that are above the level of a boarding care. Boarding care is considered an outpatient facility. An individual that would meet this level of care need do not require continuous supervision of care by a licensed, registered, or vocational nurse, except for brief spells of illness. So a little less supervision. And lastly, they do not have an illness or injury or disability for which hospital or skilled nursing facility services are required. So if there's a medical necessity for a higher level of care and the individual is also diagnosed with a developmental delay, they would not meet the qualifications for an ICF. Next slide. Generally, this is probably the bulk of the facilities that we recommend. This, per the 22 CCR, a SNF is a level of care provided by SNF meeting the standards for participation as a provider under the Medi-Cal program, and they're set forth by the 22 CCR section 51215. Skilled nursing procedures provided must be furnished under the direction of a registered nurse in response to the intending physician's orders and are either performed or supervised by a licensed registered nurse or a licensed vocational nurse. Now, a need for one or more skilled nursing procedures does not necessarily indicate a medical need for skilled nursing facilities. Rather, the need must be for a level of service which includes the continuous availability of that procedure, such as, but not necessarily limited to, the following: administration of intravenous medicines, intramuscular or subcutaneous injections, intravenous or subcutaneous infusions, gastric tube, insertion or replacement of catheters, application of dressings, involve prescribed medications, things that are ongoing, not just one. So a lot of times from the general acute hospitals, we're referring for that ongoing need of ongoing medical interventions like mentioned here. Go ahead and go to the next slide. So the other type of bed we recommend, or other facility that we also identify here, to 22 CCR 72443 STP service unit. Special treatment programs shall provide programs to individuals who have a chronic psychiatric impairment and whose adaptive functioning is moderately or less impaired. Services are therapeutic, including pro-vocational preparation, pre-release planning, provide mental disorder persons having special needs in one or more of the following areas. So an individual due to a mental health disorder that continuously needs self-help skills, behavioral adjustments, interpersonal relationship assistance. To be eligible for an STP bed or STP services, the patient's condition should be responsive to STP services. So this is why when we make that recommendation and the individual has a high medical need, or sometimes it's just a medical need at all, the facility will not accept the individual because the medical need takes precedent and the individual, due to the medical issue cannot participate in the STP program. The facility shall not accept the care of any mental disordered patient who has identified program needs unless Department of Healthcare Services have approved the facility specific special treatment plan. And all of that is to say is when you recommend and the CP reviews it, we identify that, yes, we do also concur that the individual needs the STP bed, that there's a TAR request for that placement. All right, let's go ahead and go to the next slide. A little bit more about STP because of that delineation or the difference between a SNF and an STP. Now, the special treatment program bed is improving the adaptive functioning of chronically mentally disordered individuals. Now, be aware, STP beds preclude residents with increased confusion and or cognitive functioning decline. This means NCD residents, even if not primary, may not be a good fit for an STP bed. Enabling some individuals to move into a less restrictive environment and prevent other individuals from regressing to a lower level of functioning is also one of the benefits of an STP bed. So on average, the individual that we recommend an STP bed for must be able to program a minimum of 27 hours a week on treatment focus on mental health disorders. Next slide, please. So this slide outlines some of the possible program services provided to individuals. Programs are tailored to the individual's needs. The facility shall have the capability of providing all of these specialized rehabilitation programs, and individual programs will be devised based on what the facility believes is appropriate through their own assessments. Next slide. So, in order to qualify for a special treatment program services, the individual shall be reviewed and approved by the local mental health director or designee. So when we recommend, that facility does receive its own approval that is outside of our purview. The facility program plan shall include provisions for accepting the following. The facility, in conjunction with the local mental health director, shall make an initial individual assessment for each one of the patients to identify the current level of functioning and program needs. At least every 4 months, the facility, in conjunction with the local mental health director, should determine the ongoing need for that individual to stay in the program. All of this is to say, this is on the onus is on the STP. So when you all recommend the STP bed, I want you to be thinking that would this individual benefit from these interventions, and do they have anything that would impede them from their ability to participate in an STP program. So next slide, please. So again, what does this all mean as you're interviewing your resident and you're trying to identify what's going to be the best trajectory? Positive level 1 screenings are automatically sent to us, and then we send them to the DHCS contractor, which is you all, for reviewing and processing. When the DHCS contractor calls to schedule that level 2, they will be asking questions containing PHI to determine if an evaluation is deemed necessary. You're going to explain the process from the contractor's point of view to ensure that you can make that linkage with that facility. So you've done that. You're sending your evaluator out. Next slide. So here's some little caveats to think about when you're starting to make your recommendation for placement. There's ICF versus SNF and STP. The contractor deems a level 2 is necessary. They will schedule a visit. The visit may be conducted face-to-face or telehealth. During a face-to-face visit, the evaluator will travel to the facility Upon arrival, they will present their letter to introduce their introduction and introduce themselves and show their ID badges. They will need to have access to the medical records along with conducting face-to-face evaluation with the individual. And the other important part was probably that collateral piece. So your evaluators are going to go in, have access, hopefully have access to the medical record and be able to do the collateral with the individual, with an individual who knows the resident. This slide right here is really just a kind of a reminder that ICFs over the age of 65, residents can be admitted to those facilities with no active medical or mental illness, but could still use increased support to get to medical appointments, reminders to complete ADLs, but can't do them generally on their own. It doesn't require rehabilitative services and in order to function, and most likely have been in a acute care hospital or general acute care hospital or SNF for a long period of time and could benefit from that step down. Now, SNFs under the age of 65, the Department of Developmental Services, or DDS, most likely would have placed the resident in an ICF, because if we see a DDS resident, they also have a mental illness that needs active care, they would need SNF level of care. So when you have an individual that also has that developmental disorder, that's co-occurring or a dual diagnosis, you could still refer to a skilled nursing facility if you believe that they would benefit from that additional higher need of care and would meet medical necessity. Next slide, please. So accurate bed type placement means accurate services. There's an individual that is at the end of all of our evaluations. So as we focus on gaining or gathering the information, that's important. Just remember that making that accurate bed type placement recommendation means that that individual will receive the accurate type of services. It's crucial. Services are rendered based on medical necessity and regulations. Incorrect bed types can mean that the resident will not receive the services needed to rehabilitate and return to the least restrictive environment. Also, just sort of a caveat there, we do make mistakes, or there are times when the acute care hospital says that, you know, there is no bed. We can't find an STP. We found a SNF that can offer these things. They will put in a request for reconsideration form, and that is located within our PASSR system. I'm sure that we will receive additional training on how to do that. But if you are ever asked by any hospital representative, you can redirect them to the system. Next slide. Administrative issues. These are things that as a CP or a consulting psychologist that are frustrating, and hopefully we can minimize any errors, because again, the individual gets a copy of the letter. It gets a copy of the information that we are gathering. So if the resident's name is incorrect, if it's you know, squished together all one instead of separated by first and last name or things of that nature, it will go out like that. Are you using DHCS approved acronyms? Those acronyms should have been given to you. It is just way too difficult for us as DHCS CPs to identify what list or what you might be saying if it's like an alphabet soup. So please, if you're going to use acronyms, use the DHCS approved ones so that we can look them up and be able to understand what you're trying to tell us so that the resident or the individual receives the services that they need. Gender and inaccurate pronouns is not only sloppy, but also does not align with DHCS diversity, equity, inclusion philosophy. So please make sure that you are identifying the proper pronouns. Next slide. Let's see here. Clinical issues. So, a delay in my laptop, sorry. So specialized services are distinct to etiology. So what you are doing as a clinician is using your clinical judgment to summarize the information and give reasoning for that level of care placement and specialized service recommendations. We would appreciate if you don't make us guess that you understood the issue. Like, we like that you identify that the individual would benefit from or would not benefit from, so that as we are making our placement recommendations based off the information that you all gather and share with us, that we can identify whether there is a clear issue due to a medical or mental health issue. Distinct information in each evaluation sections are paramount. Please don't cut and paste your reason for referral into your summary. We already read it once. We don't need to read that twice. It's a waste of your time, waste of ours. Consultation is between two individuals. I haven't seen a lot of consultations lately. Evaluations have been looking pretty clear cut, but there are times where there's something that we also need to get clarity, but we don't want to call the facility. We will reach out to you first through consultation, and hopefully we can work that out. Next slide, please. So the final thoughts here is consult with the DHCS website below here for the most up-to-date SNF and STB LOC bed facilities. They're supposed to update them, but again, I'm assuming reaching out to a PASSR representative will also be beneficial if you're unclear of the level of care of the facility that is either being referred to, or they're asking for specific services. If you need assistance to understand if this facility that you are in offers those already as an SNF or STP LOC. And that's all for me. So you can stop sharing now, Thomas.
All right. Are we going straight into the demo, or are we doing questions?
Let's go ahead and see if there are any questions.
And Andrea Stewart has her hand up.
Hello, everyone. I have questioned is on the PASSR level 1, what is the reason that they don't indicate the reason why they're submitting it? Because we're being asked information about the reason for submitting it. And a lot of times the person who submitted it isn't available when we go. So we do have to ask the nursing staff if they can go look at the chart, and that takes a lot of time. Is there any plan to consider modifying the form?
I mean, Thomas, I think that's a good question for you. For you, I have not. Yeah, that's you.
So I mean, the reason why the facilities are usually submitting the level 1 is because there's some indication that the person needs to go to a skilled nursing facility. They're supposed to be identifying specific information on the level 1, specifically in sections 3, if they have a diagnosed or suspected serious mental illness, and they're on psychotropic medication for that diagnosis. If they're not listing that information, I mean, the screening won't go to you guys. It'll just close out on our end. But I mean, it's assumed that everybody that's submitting a screening and it's positive, there's a plan for them to get discharged to a SNF. But is there any information you all are missing specifically that you're looking for?
Oh, yes, let me clarify that question. I'm more so referring to when that level 1 is resubmitted. Like, for example, they came from the hospital, they've been at the SNF for maybe 4 months, 2 months, whatever, and then it's resubmitted and it appears to be a duplicate after an assessment. So they're asking us, why are they resubmitting it within like maybe close proximity, sometimes from days all the way up to maybe 6 months to a year. So
Yeah,
those instances,
yeah, in a perfect world, the resident review is supposed to be a status update. So there's supposed to be some change between the first screening that was submitted and uh, resident review. I'll keep wanting to say reconsideration, the resident review. But sometimes we're seeing facilities like the SNF didn't get the documents they're supposed to get from the hospital, so they may submit another screening to cover their finances, um, to just make up any days that might have passed between the admission and them not getting the documents they need. If that's the case, um, then that screening is a duplicate. But we are doing outreach with the facilities. We run reports to see how many SNFs are doing this and try and educate them weekly. But yeah, ideally in a perfect world, if you see a resident review submitted, it's supposed to be different than the initial one. And then you guys can make the decision based off of that.
Thank you very much.
Yep.
See, there's a request for the PowerPoint or the link to the facilities in the PowerPoint. I'm assuming that that's something that we can we can send over, right, Thomas?
Yeah, I think so.
Awesome. Thank you. Any other questions?
I have one point of kind of clarification that I think might help. That nobody's asking, and it's not really the kind of thing anybody would ask a question about. But we presented the different levels of care almost equally, but just anecdotally, it's extremely rare that people get recommended for the ICF. It's 99, more than 99% of the time, it's between the SNF or the STP. Just to put in perspective for anybody who's sort of new to this, I think most of you have been doing this and are familiar with the process and the field out there. But I mean, I think I've gotten maybe 1 or 2 ICFs since I've been at PASSR, and that's been 10 years. So it's just to put that in perspective for you.
Thanks, Carl. You want to go ahead and move into the demo?
I can. Hi, everybody. Actually, I didn't even introduce myself yet. I'm Dr. Bonacci, Carl Bonacci. I'm one of the PASSR consultant psychologists, and I've been here for about a little more than 10 years. Right now, Thomas is loading the level 2, which is the form that you will see when you're filling out a case. I'm going to go through it pretty quickly. It's become much better. We've evolved this system over time, and it's gotten much more kind of self-explanatory. So it's a simple form with a lot of drop-down menus and areas where you can enter information. But I need to zoom in on this because I can barely see that now on my screen.
I can zoom in a bit.
Can you a little bit?
Yeah.
Okay. So I think it's outside of the purview. This presentation is show how to kind of log in and get into the system and all that. I assume everybody's gotten that training. Now we're just doing the clinical assessment process of it. So when you first open up, you get to this page. Some of the information is auto-populated from the level 1. So you just start with the first question. Reason assessment was not completed. If for some reason you end up not doing this assessment, so during the pre-screening phone call and through that process, or at any point in time before you actually conduct the evaluation, if you need to end this evaluation, that's the button you click. And there's a few options in the drop-down menu. Once you click on one of those, like for example, yeah, there you go, click attempt, and then you have another subset of items you can select. So there, perfect example. And that's a good example of how like a lot of these menu items are drop-down menus, which are hierarchical, where if you select one item in there, a few other options open up for you. But if you don't select anything, if you don't need that item at all, if it's not applicable, then the additional subsequent items don't show up. So and that was an example where there were, I think, 2 subcategories, and then a text box opens up, and there you can fill in freehand what other kind of information you want to add, any other additional explanation. So Thomas, can you zoom in a little bit more again and just click on that reason for assessment not completed again so everybody can see it. Just go to attempt, same thing. And then so there's the drop down menus. You guys saw that if you're watching when he did it before. You don't need to do it now. Just back out of there and remove attempt. Okay. So that's also what you could do if you, for some reason, click that box, selected something and needed to get out of it. Just go back to the top item, select, and it'll let you pass. It'll let you move on to the next items. And Dr. Cho, jump in anytime. I'm going to go through each of these items, or I'm just going to go through these screens pretty quickly. Like I said, most of them are self-explanatory. It's asking
sure.
questions about something like cardiology, and you just answer that question. But if you have any points, any areas that you think were real sticking points, or areas we've had to have some sort of further explanation in the past, jump in. But
Sounds good.
okay, so I think Dr. Cho had mentioned make sure the name is spelled correctly. It's a frustrating thing that's really simple to overlook, and then also something we need to correct right off the bat. Date of birth, I think, gets entered automatically. The rest of these items are things that you just click on and select. There's gender, marital status, race, education. So I'll let Thomas go through and click on any kind of random entries you want.
You want me to just keep going through all of them, or do you want me to stop at a certain one?
These things like who participated in the in this evaluation. Hospital staff, you always have to include the resident. If they decline, you can mention that later. And most of these items have an other selection where a drop-down box will show up like he just did, and you can enter in whatever additional information you want. Okay, then reason for admission. This is where I like to see a lot of, or just really clear information here. The reason that the person will meet the requirement for nursing facility level of care. So whatever the reason for their admission is, it should be something that stands out and is really apparent to us, that this is something that qualifies for needing nurse facility care. You can go on from there. Just keep going through those, Thomas. Obviously, to everybody, I'm sure this is apparent to you, but all the ones with a red asterisk are items that are required to be filled out. If you skip any of them, when you go to save it or to submit it later on, it takes you all the way back through, and you have to kind of find it and make sure you fill that part out. So it won't let you continue. Okay, here, go back, shrink up this section for 1 second, Thomas. Okay, first you click on each of these banners or sections. It'll open up that section. So the whole thing is separated into five, what is that, 6 sections? No, yeah, 6 sections. So you go ahead and click on the next one. You see this is physical illness. The next one's going to be psychiatric, and then uh, the other ones get into the recommendations. So here, if they have no current health problems, which is extremely rare, but if they have no current health problems, you could click on the no box there. Thomas, click on that, and that will allow you to move forward into the submission of this case. Um, all of the subsequent items are by default marked none, and then as you go through, you mark any affirmative selections that apply. So go back up and remove that current health problems. Okay, and now go through and just pick some randomly. And again, this is one of the areas that's very self-explanatory. You're going to do a lot of this part of the evaluation you can do based on just a record review. So it used to be we had to do this in the facility. You you go there, you get the chart, review it, look at the MARS, the medication administration records. And with both those sources, you can fill out most of this information. I think you guys get a lot of this online now. So when you get the digital version of their documents, you can fill out a lot of this information. And it's just a matter of looking through all the corresponding sections in their chart. Coincidentally, it also does somewhat follow the MDS. It doesn't really. So let me explain. It used to, and over time, our evaluation has gotten a little bit less matching to that, but you can get some of the information off of there too if they've had a recent one. All these things, obviously, like I said, infections, metabolic disorders, musculoskeletal disease, neurological syndromes, nutritional issues, pulmonary. It goes in all these different sections, and you just entering it from the chart data. Okay, now we're going to the next section. This is more around mental health issues, psychiatric issues. You click on one of those under substance abuse, Thomas. So you click on any of these selections, you get a drop down menu, and you categorize the severity of it. If you don't know, you can put NA, mild, moderate, severe. I think you can unclick that if you want to. Yeah. And this section,
Carl, I apologize, but there is a question here where it says, what do you mean by injections in that section? Does that mean IV meds, IM meds, diabetes injections? So
I'm trying to remember where that came from. I think it was, do you remember?
right, it follows the MDS.
Yeah,
so it would
exactly.
be wherever an identifiable injectable is. So if they are on Haldol Deck every 6 to 8 weeks, if they're on daily IV fluids, all of that will go in there. That's the only question I see right now, Carl. Thank you.
Right. And there's another section where we put medications that they're on as well, which is coming up. Each of these sections, you click on the box to the left, and then you can fill out how often this occurred in past 60 days, 30, 60, or 90 days. Frequency is unknown. You can click the on frequency unknown box. Okay, these are psychiatric medications. You click on you add new, and then you type in the name, dosing.
So
The
just
daily dose needs
interjecting here, sorry, Carl, that this sort of substantiates that the particular way that we add PO or by mouth medications, you wouldn't be able to fit like the injectable, like your Dex, their
Right.
Haldol injections here. So that would have to go up in the other place because there's not a every 30-day option here with the dosage or the frequency.
Right. Um, you can, so down in this section where Thomas is has cursor now, that text box, you can add additional information about these medications. It's really helpful to us if you in the name section of the entering the medication, you put the reason. So it'll say, like um some of the SSRIs might be used for depression or for anxiety, for example, and you could just add that information for anxiety or for depression. You can also add any additional information down here, um, referring to the medications. It's just an additional box for you to add information that you think is relevant, but there's not a drop down text drop down box for. And then um, under non-psychiatric medications, you can enter the same thing. You enter information for other non-psych medications. Then you keep going on. Most of this next few questions are going to be pretty self-explanatory. Any of these symptoms that they have, you click the box, and then there's a drop-down menu where you can give a little brief description. You can keep your descriptions very brief and just to the point. So we get an idea of what the what you're seeing and what your perspective is on it. This I think is clear, but under social support, personal hygiene, um, you kind of have their own report and then what's observed because a lot of times those two perspectives might conflict on these items. So we put up two boxes in there for you to kind of keep it separate. Yeah, we kept mood as just an open text box. There's no drop down items or no uh what are they called, the items, checkbox items. It's just a description, so you just describe their mood in their freehand. This is a very brief neuromental, like basic, almost like a mini mental status exam. It's called the Blessed. It's based on the Blessed, and it's a series of a few questions. What are there? 6 questions? Can you scroll up, Thomas?
Yep.
So you answer each one, enter the score in that box, and then the rest of it gets auto calculated, so you don't have to deal with calculating the final score.
Carl, there is
Yes.
a question or a hand raised, and it came up right when you came to this. So I'm assuming it's related to this. Do you want to take that question now, or do you want to wait?
If it's related to this, we can take it now. I don't see it in the chat. Do you?
I know, that's why
wanna-
no, her hand is raised. I'm monitoring it.
Oh,
You go ahead and
okay.
take care. So Andrea, is it related to this particular section?
Yes, it is.
Perfect, go ahead.
Okay, this is my second stint with PASSAR. The first time I was with PASSAR with the same agency, just a different name, it was stated that you go by if they say the words in the right sequence. If they say the words out of sequence, that's considered a mark. But this time, I was told it doesn't matter what order they say it in. Can you clarify that?
Are you talking about just the memory phrase?
Right.
Okay. Thomas, can you scroll so we can see what's above this section? Okay. I can barely read this. Okay. First, to
Sorry,
answer
I'm
your
gonna
question
zoom
really
in a little bit.
quickly, is as long as they
There we go.
mention the item, you can score it. It
Okay.
doesn't need to be in sequence.
Thank you for clarifying.
Thank you. All right, I don't have anything else in the question there, Carl, so you can go ahead and
Okay.
move forward.
Okay, go ahead. Okay. Here we have the diagnosis, or it's the action is similar to entering medication. You click on add new, and then you write in their diagnosis. And these are your diagnostic impressions. You could enter, you'll get that from multiple sources, your own clinical impressions, and from what's uh, what's listed in their chart. To clarify anything, we give you a text box, just a free form box where you can type in anything you want to add to kind of clarify to us, to convey to us what your thinking is about these diagnoses, or any issues that you have that need to be ruled in or ruled out, or any concerns you have about the diagnosis. Physical diagnosis, same thing more or less. You could just be very just succinct, list the physical diagnoses that usually are found in a diagnostic list in their chart. There's usually a summarized sheet that has just their diagnoses on it. That's a pretty simple way to get it. It used to be a yellow sheet in the chart. I don't know what it is now, or how it is on electronic charts. Okay. This is where you're getting into recommendations, or kind of your views, your comments on their ability to live independently, and things that are going to weigh toward their need to be in a nurse facility. If they were in the community, they'd have a difficulty budgeting money, maintaining employment, getting clothing, taking care of themselves, finding shelter, all those things. Same thing with these next questions. Item 76 is individual strengths. So just list their particular strengths. That's a free form box because they're just it's idiosyncratic. There's so many that you could choose from that we just gave you a free form text box where you can enter in just briefly again what the individual strengths are. Discharge plan, if there is a discharge plan, if there and those are there. There's an active discharge plan in place. And then select whichever block boxes apply. As you go through this evaluation, you just find in the real world things that you feel like the this real like categorized approach to filling out a clinical form or an evaluation of somebody doesn't catch everything exactly right. So this is a place where you can clarify any inconsistencies or anything that might look odd to somebody viewing it. And it's a free form box for you to um, write in exactly what you want. Looks like a few more people just joined. Okay, brief case summary. Again, this is kind of at the end of the evaluation now, you have a clear view of who this person is. And if you were to convey to us, say, you are recommending this person for entering a nurse facility, we just need, you want to give us a call and you want to give us in as few words, just as directly as possible, who is this person? Why do they need to be in a nurse facility? And what are the issues that came up in their evaluation? A very brief case summary. Jennifer, is there any other distinct things that you think someone needs to include in that section? That's always a section that we've kind of evolved over time.
Yeah, I think one of the things that's has been very helpful is when the evaluators identify really just a summary of where they saw the individual, how they saw the individual, and the areas of need, medical necessity need, and then their recommendation. It doesn't have to be long. So interviewed individual at a GAC due to this. I mean, just really clear, doesn't have to be jargony. And that has really just been what we have been looking for. It really helps us hone into the sections that we need to look into further based on your case summary.
Okay. 99% of the time, almost always, when these are an individual who's going to a nurse facility, the answer to question number 80 is yes. Are nursing facility services needed? That question's there because that's just the basic reason for PASSARs to determine whether or not nurse facility services are needed. So it's a very clear answer to that question. And they in these cases where you guys are filling this out so somebody can go, the answer is always yes. It's extremely rare again that the answer comes out no after that, after all that evaluation. And then here's where you enter the recommended level of care, special treatment program, skilled nurse facility, or ICF. And now you're going to recommend all these different levels of additional services. So medication, education, training, ADL training, education, vocational services, all those things. You just click on them and enter whatever supportive data in the box. Same thing in this one. These are functional medical consultations, psychology eval for diagnostics and clarification of their condition, maybe psychiatry if for medication recommendations. There's neuropsych, internal medicine, cardiology, anything that pops up in the process of your evaluation that is an area you think they need follow-up care for, then we will add those to the recommendations.
Thomas, do you mind zooming out of 82 so that I can see 82 and 83? Daniel Kwan has asked, what is the difference between 82 and 83? Some of the categories overlap. So,
You want me to unmark
82,
these so you can see them all?
please.
Yeah.
And I'll zoom out a little more.
Well, though not too much. You know, I'm old.
I know.
I can't see nothing. That's cool. So, Daniel, did you want to unmute and ask a little bit more clearly, or is it pretty like why are there some that carry over?
Sure.
There he goes. Go ahead.
So as you can see in 82, some of the categories, for example, medication education or ADL training, psychotherapy, counseling, are repeated in section 83.
Yes. So one of the things that so that has evolved over time, but with 82 in particular, these are services that could be done by a non-mental health, how do I put a paraprofessional? So maybe a psych tech or a case manager, some of those things that are supplemental by the people that may be supportive. But the 83 is a referral really for an evaluation for those particular services. So that is the delineation that the evolution of this interview. Yeah, thanks. So 82 is like services that could be rendered without the need for an ongoing or more direct evaluation. So I'm trying to, is that sounding okay? Thanks.
83 is more, you can see, or yeah, you can't see this. 83, you can see each one of them is a consultation. It's usually where there's some ambiguity about it, or it's not finally clear. Like, say 82 has some services. For example, I don't know, substance rehabilitation. That can be done by one of the individuals, is someone from 83, but those are recommended services. So we're recommending you to this individual for medication education and training, and that could be done by someone in the facility, the social services director or something, or any of the treatment staff at the facility. The 83 is consultations for more clarification. Those are all professionals who will, at the end of their evaluation, give more specific recommendations. So, a speech therapist or dietary consultation. And then, as I mentioned, like neuropsychology to clarify what their specific cognitive strengths or deficits are. Those are things that are not included in 82. Is that clear enough?
Not really, because I mean, to some degree, it sounds like you're saying 82 is for services that can be provided by nursing level and paraprofessionals, and 83 is for like having a doctor come on site to provide a service.
Okay.
Is that correct?
That's pretty
Right.
accurate.
So what the facility that they will be going into can offer 82. So anything in 82, those are things that generally are already offered or provided by that facility. There wouldn't need to refer out. It's not a further examination if it is needed. You're saying it is needed. This is something that they need. But again, the delineation is, are you referring to see if the service is going to be beneficial, or are you referring that service that's going to be provided in that facility or should be provided? An individual should go to a facility that has that service already provided versus an individual should go to a facility and an evaluation for a psychology consultation or a pharmacy consultation is needed. When in doubt,
Okay.
recommend both.
Yeah.
Alrighty. Well, thanks.
Okay, Thomas, you can move on from there. Okay, here at the end, I think now the contractor, the name of the evaluator is auto-populated. I believe that's how it is
Yeah.
right now. It was that they had to enter it, but now we've updated it so it's auto-populated. And the final step is make sure you check that box all the way at the bottom. Thomas, can you uncheck it and check it again, or yeah, point that out? Just indicating that the resident was informed about the purpose of the evaluation and that their statements would be included in the PASSAR report. That's just the requirement for informed consent. And then at the end, you click submit. And let's see if we left anything out. If you leave anything out, it'll take you back up and you go through each of those red asterisk items and make sure they're filled in.
A little tip, when you're hitting submit, if there's a delay before anything happens, that's your indication that it was submitted correctly. You fill out everything.
Right.
Like Carl said, if you miss something, as soon as you hit submit, it's gonna let you know. It's not gonna do anything.
And there you go. Now you're back to the start screen, the
Yep.
dashboard. Are there any other questions?
I don't see any in the chat and I don't see any hands. I do see familiar faces. So well, I guess not faces, but familiar names. So these seem to be individuals that have been doing this work for some time. Is there any feedback from those evaluators? Like I think Andrea Stewart has been with us forever. I'm seeing some common names in here. Angelica, Ashley Cortez. Any of this information confusing, or is there any tips that you would like to share or questions that you might have after many years of doing this? That would be helpful for newer evaluators. Well, I think that it must just be very clear and concise that there's nothing in there. So I think we can move on.
Yeah, I think the system's gotten much more intuitive to work with. So it used to be we were working with old what was it, like the C prompt black screen with green lines and letters. It was really
I
old from
call
like
it
the 80s.
DOS, but yes, the DOS
Yeah,
system was
DOS, the
very
old
fun.
DOS
Yeah.
system. Yep. So yeah, it's gotten much better now. And if anybody has any questions after this, you can just submit a question to us or let us know and we'll address it in our next meeting.
Yep.
Well, Thomas, I think that's all we got.
Yep, I think so.
Great. Then thank you, everybody.
Thanks. Kelly, we'll get you the recording as soon as we get it uploaded to YouTube, because I think you all don't have access until we upload it to YouTube.
I'm not sure. I think this might be the